All right, hello and welcome to another educational session on nerve surgery through the AANS CNS section on disorders of spine and peripheral nerves. My name is Jared Pisapia. I'm a neurosurgeon at Westchester Medical Center in New York. I'm joined by my colleague, Rizk, a neurosurgeon at the University of Texas at Austin. We're very pleased to welcome Drs. Martin Malessy and Howard Clarke for discussion on birth-related brachial plexus injury. So Dr. Martin Malessy is professor of nerve surgery and head of the Nerve Center at Leiden University Medical Center in the Netherlands. Dr. Howard Clarke is professor in the Department of Surgery and Physical Therapy at the University of Toronto. He recently retired from clinical practice in the Division of Plastic and Reconstructive Surgery at the Hospital for Sick Children in Toronto. Both have served as past presidents of the American Society for Peripheral Nerve and contributed tremendously to the field of nerve surgery. So we're very pleased to welcome them to the series, especially as our first international collaborators. So we'll start out with just a very brief introduction. Birth-related brachial plexus injuries, or also known as obstetrical palsy, occur in about 1.5 out of 1,000 live births. The majority of these will recover, but for those that don't, these conditions can lead to significant impairment in the use of the upper extremity as well as quality of life. The mechanism here is typically a stretch injury where traction is exerted between the head and the shoulder. Risk factors for this include shoulder dystocia and macrosomia. This picture shows different types of nerve injuries. The first one is an avulsion type injury where the nerve root can be pulled out from the spinal cord. Other types can be where the nerve itself is ruptured or the nerve is stretched. The first type is considered a preganglionic injury occurring proximal to the cell bodies, whereas the others are considered postganglionic. And so with that background, we can talk a little more about some of the clinical diagnosis and workup. So just to open up with the first question, it can be difficult to examine newborns. Any pearls for the group in terms of trying to gather information about a brachial plexus injury in a newborn?
Tim, why don't you go first?
Well, any pearls?
How's how you approach the exam? Anything that you sometimes just the resting position can be telling. Sometimes spontaneous movement can help.
Yeah. We observe spontaneous movements, and we tend to see the children very early. Try to see them already at 1 month of age, and then get them back in the month later on and follow the potential improvement. Look at the joint stiffness, but it is especially indeed the discrimination between so-called trick movements and actual muscle function that is sometimes difficult. Like infants are able to flex their elbow, whereas the biceps is not functioning. And in these specific cases, for instance, you look at the position of the lower arm, whether the arm is in supination or in pronation. You have to combine specific movement patterns to see whether a specific muscle doesn't function or whether it's a trick movement and that's the difficult part.
Yeah, absolutely.
So what I would add, if you want, is patience is very important, and practice is very important. It's not something that comes easily the first time you try it. And I know that in Holland as well as in Toronto, we rely on our therapists to do many of these assessments because they're very good at handling babies, very good at looking after things. They learn the scales necessary very easily, and they can provide a great resource in assessing these newborn babies.
Great, and you had mentioned scales. I know you've contributed to or created this scale. Maybe you could talk a little bit about the active movement scale.
The key principle here is that you can't reasonably expect to see volitional movement on command in babies. They will simply not do that. So scales like the MRC scale although some people say they use them, can't really be applied. If you simply observe the total amount of arc of range of movement, either with gravity or against gravity, then you can get something you can measure in a brand new baby the first day you meet them and a 18-year-old kid who's at the end of his treatment path. So that's why this scale was developed. The key thing is not to give falsely high values for small amounts of movement. So you have to score 4, which for elbow flexion is full movement through the elbow with gravity eliminated. You have to get that score 4 before you're allowed to score anything for any anti-gravity movement, which would be a 5 or 6. So little movements don't get you to 5 or 6. It has to be full movement with gravity eliminated first.
I would add potentially on the physical exam, looking at the pupils to make sure the sympathetic innervation is probably intact or not, to quantify the degree of involvement of the lower trunks. And one thing I learned from our therapist is doing the Moreau reflex is an easy way to trick the infant to try to raise their arms so you can see, shoulder function a little bit better. So these are small things that you can add into your armamentarium to be able to examine the patient a little bit more effectively without really, pitching or trying to make some extra maneuvers. Or not sure what your thoughts are, Dr. Malessy, and how Dr. Clarke.
Well, the key thing, as you've already suggested, you can't do anything that hurts or disturbs the baby. It has to be a view of spontaneous activity, and that's why the patient sometimes is required.
Awesome. Thank you.
I would also add sometimes palmar grass reflex can be intact, and that's something else to look at the lower plexus. Another score, do either of you use the modified mallet classification?
Yeah, we absolutely do use it. Basically, later on, after specific interventions to document the outcome. This is not, I think, very practical to use as a, to document function prior to surgery. I mean, that's not what we use it for. We use it mostly after a couple of years to assess especially the shoulder function. Yeah.
It's a good way to remember to examine the other limb, because sometimes it's all focused on one side. And like we mentioned, Jared, about the lower extremities. So there's a few percentages of them that have bilateral findings, but because one is more pronounced or more affected, the clinicians focus on one side and ignore the other side. And that helps the therapist too, to do the interventions and therapies to help them in the long run.
That's a good point. And in terms sometimes of prognosis, I've used the Nerakis classification. Do you find this a useful classification system in your practice?
I have not found this useful. It doesn't really tell me who needs an operation. It's not a scale that can be used to compare across treatments. You can't use this in a statistical fashion. So we don't use this at all, simply because it doesn't really add value in our situation.
No, I completely agree. I mean, we also don't use it. And actually, if you look in more detail, I mean, you can describe roughly 12 different types of lesions, depending on whether it's a neuropathic lesion or an avulsion, different combinations. So we describe the lesion as it is, not in a group.
Yeah. I think it's an interesting observation that there's so many different scoring systems, classification systems, and such a heterogeneous injury pattern. So it's interesting to see what some groups use and others don't find as useful. All right, so we could move a little bit to some other testing. For pediatric or obstetrical brachial plexus injury, do you use MRI to guide your decision making?
Well, we certainly do. We certainly do. We select them, try to select babies for early surgery, like from 3 months onward. And in this decision-making process, we use MR myelography.
Our addition to that, which you may already be doing, Martina, is we'd use cone beam analysis as well, because the cone beam tests actually give us very good views of the filaments. So we can get a very good assessment using that.
And with MRI, at what point are you typically obtaining these studies? Is it shortly after injury or closer to, or at least after 3 months when you're considering a surgical intervention?
We only do these diagnostic tests if we've already made the decision to do an operation. So we're not doing it needlessly in a whole bunch of babies who are never going to have an operation, because it's only academic in those babies.
Right. And in the surgical cases, you're using it, I imagine, more to plan out the type of surgery, if it's preganglionic versus postganglionic injury.
It's added to the list of things that give you the information you need when you do the exploration to decide what's going on with this particular route.
Right. That's well
Dr.
said.
Clarke, how would the cone beam MRI help you with the decision making if you're looking at the fibers? Can you clarify that point that you made?
It seems to give us a more accurate assessment of whether there's avulsion of the dorsal and ventral rootlets, because of course you can have one without the other, or a mixed pattern even there. It's not perfect, it's not absolute, but it gives us a better sense for that, because we do have roots where it seems there may be some viable motor conduction, but there's evidence of avulsion of rootlets as well. How do you reconcile that?
Very nice, thank you.
And we talked a lot about MRI, especially in babies. Is there ever a role for CT myelogram?
Not anymore.
No.
Okay, that's similar to our practice as well. All right, and another question that comes up a lot, families or certain therapists will ask, is it okay to begin physical therapy immediately once this diagnosis is made that there's a brachial plexus injury, assuming there's no clavicle fracture or other injury? How do you usually answer those questions?
Well, I think that it is extremely important to start physiotherapy focused on the prevention of contracture formation, especially in the glenohumeral joint. It goes very fast. So yes, I think that as soon as the baby's diagnosis made, you have to start. Yeah.
Right.
So it is just maintaining passive range of motion. It's not making things better. It's not achieving anything else, but you want to maintain passive range.
Perfect. All right, good. All right, so
What about EMG testing? How often do you utilize that in your clinic? And some units are not fortunate to have pediatric EMGers or neuromuscular specialists. What's the best way if you're going to set up brachial plexus clinic to evaluate patients and utilize the best resources to do those EMG tests? Is it just at the time of decision to surgery, or do you get them in a focused way? So how would you do that at Toronto or Netherlands?
Well, it's an easy answer in Toronto. We don't do them at all. The good evidence that came from Holland, from Dr. Fledevelt and his colleagues, was that these were overly optimistic assessments in newborn babies. And so they didn't give us useful prognostic information. They didn't help us decide what we're going to do during the operation. So we simply do not use them at this point.
So they are only useful at the age of 1 month. So we use EMG at 1 month and only of the biceps. So there's one needle insertion in the biceps, and the absence of action potentials has quite a good relationship with a poor function of the biceps at 3 months. So like 85% of the infants who do not have any action potential in the biceps at 1 month do not have a biceps function at 3 months. So it helps us to already detect in a very early stage which infant might go to further surgical treatment, for instance.
So it sounds like that's more prognostic, if anything, at that stage. Okay, all right. And I think from that we could maybe segue into the difficult decision about timing. So if you have a child who has a deficit who's not recovering, maybe you could both give your general approach. I know that every injury is different, but in general, how do you determine when to intervene in kids with a brachial plexus injury that hasn't recovered?
I can start if you like.
Sure.
The key, I've spent 30 years trying to figure out if there's one way at one time to decide which baby needs an operation. And after 30 years of looking at this very hard, the answer is no, there is not. So as you said at the beginning of the talk, this is a very widespread, heterogeneous population. All you can reasonably do is identify the babies with the very bad lesions and operate on them very early in our case, as early as 6 weeks, but follow the rest of them along to other possible points in their recovery where you may say, gee, this isn't good enough and we better go ahead and do something. So in our case, we'll wait even till 9 months of age in the mild injuries to see, is this sufficient recovery or should we be doing operation? So there's no one magic way to see who needs an operation.
But that's helpful to hear the trends that a more severe injury tend towards intervening earlier, a less severe give them more time, and go from there. How about Dr. Malessy? Similar?
Yeah, we have a slightly different approach in the way that we see a surgery also as a means to get more information. So we accept a maximum of like 10% of cases where we explore the lesion and in the end feel that grafting or transfers are not necessary. This approach is based on the fact that we want to schedule all the infants early. So we never wait until 9 months because as we know that the regenerative the regeneration is less when you wait longer from the time when the interval is bigger between the trauma and the repair. So it has early exploration has the potential that you go too early, so to speak, but it also gives the opportunity to do really tailor-made reconstructions. It is not always that, for instance, the entire superior trunk is damaged. Sometimes we do partial repairs, partial parts of the superior trunk are more severely damaged than other parts. So then you do a partial grafting, stuff like that.
So can I add a qualifier there? None of us have any data about the rates and longevity of potential nerve recovery in newborn babies. So that idea that we must intervene quickly is an extrapolation from adult injuries and adult data, but there's no evidence that applies necessarily to babies. And indeed, in the right situation, that's why we seem to be able to get extremely good results in the correct and highly selected patients when they're operated on later, even at 9 months of age.
I know we used the time point 9 months. Are there patients that either you'd be open to operating on or have operated on beyond 9 months? I know some people use 12 months as a cutoff. I've seen the literature even up to 18 months.
There, it's a matter of when the patient first comes to see you. And if they come at 12 months of age and they have a lesion that really might be made better by an operation, then that's a reasonable thing to consider. But if you have an established clinic and see the patients early, you shouldn't have to come to that.
Yeah, it's good.
So, and in addition, I think the goals you can reach when they come later, that's also shifting. I mean, yes, if the baby is 18 months, you can go for a biceps, for instance, for flexion. If these are rare cases, but I don't think targeting shoulder function or hand function is useful at that time. That's too late, in my opinion, experience.
Okay. All right. I thought it useful just in general talk about some scenarios. Maybe first, Dr. Clarke, do you want to just mention the cookie test?
Well, the cookie test is our exit test, if you like. So for the mild lesions who may do well, we follow them over time. If they pass our usual criteria at birth, at 3 months, at 6 months. When they get to 9 months, we give them a cookie in their hand, and with the elbow at the side, they have to bring it to the mouth without flexing their neck more than 45 degrees. So if they can do that, that's a pass of the cookie test. The baby in the picture, you can see that's as much elbow flexion as he's got. That's not sufficient, and we would recommend an operation for that child in the image.
Okay, great. All right, so we can move ahead. So I put down a few different scenarios that we might encounter. I know, again, as we spoke, each case is a little bit different, but I thought any principles or general trends that we might be able to pass on to the viewers. So, for example, if you had a baby with a C5-6 or upper trunk or upper trunk injury, can you talk a little bit about how you would approach that, especially let's say the baby is now 3 to 6 months out and really hasn't shown any evidence of recovery?
We try to do an anatomical reconstruction, basically. So we graft the superior trunk. We have identified specific quadrants in C5 where specific grafts can be put, for instance, to the suprascapular nerve. But basically, we do a grafting of the superior trunk.
So my answer to this question is actually a very simple one. Unlike my other answer, which was very messy, this is the simple answer I can give you. Our approach, regardless of the extent of the lesion, so even the mild ones, the severe ones, and everything in between, is we resect everything that doesn't look like normal fascicular nerve and everything that is not functioning like normal fascicular nerve. So an individual root or portion of the brachial plexus has to look normal, has no evidence of scarring, and has to function, has to have some conduction through it, which suggests it's actually working. Everything else is removed and reconstructed anatomically, as Martina suggested, so an anatomic reconstruction as possible. The only little quibble there is occasionally we have patients with significant damage to the upper and middle trunks and a C8 avulsion, and we may have avulsions of 6 and 7 or 5 and 6, so we don't have lots of proximal stumps. There we may leave a known avulsion of the C8 root in continuity simply because we don't have anything left over to reconstruct it with. We have to focus on the shoulder and the elbow, and we've already got T1 working for the hand. So that would be my exception to that rule. But if it looks like nerve and it's working, you leave it behind, and if not, you cut it out.
Very good.
Do you use a sural autograft or do you do an allograft for these cases?
Sural nerve autografts, which is still the correct and gold standard treatment for these babies.
I fully agree.
And is there a role for nerve transfers now that people are doing it more instead of doing an anatomical reconstruction?
There is definitely a role for nerve transfers, and most commonly in combination with anatomic reconstruction with sural nerve graft. So often you'll be doing a nerve transfer for the suprascapular nerve or whatever in addition to anatomic reconstruction. So that blended approach has worked very well for many years, and I think is still probably the best way to go. There's the data about nerve transfer alone as a complete reconstruction looks fairly good in the early years. We don't really have good late data for that to show whether those results are maintained over time.
Thank you.
So for that scenario you mentioned, let's say there's C5 is you deem suitable for grafting, but let's say there's a C6 and or C7 avulsion. Would that be the time that you would do something like spinal accessory to suprascapular nerve and then use whatever grafting you can to kind of reconstruct whatever's left?
Correct.
Is that okay? Understood. Yeah. Okay. How about, another really tough one is the one on the far right here, this pan plexus injury. Can you talk a little bit about your approach to managing these cases?
The pan plexus can be a neurogmatic lesion of 5, 6, 7, 8, and 1, which is the approach is completely different than if you have 5 root avulsions. Mm-hmm. So it really depends on the number of roots that are still available as, to serve as a source of proximal stumps for grafting.
Mm-hmm.
Usually you have one or two stumps, usually 7, 8, and 1 are out, torn out of the cord. And then the focus of the reconstruction is first to get access to the hand. So we innervate either C8 or T1 or the inferior cord or the inferior trunk, and then biceps and then shoulder. But it depends on the type of lesion.
And Dr. Clarke, I know Dr. Malessy mentioned reconstructing the hand. I know that's a little bit different than perhaps how we approach adult plexus, but do you also try to get back hand function as a top priority? And how does that compare to elbow and shoulder function?
So the hand is not a little bit different than the way we approach this in adults. That's underselling this so much. The hand is the only important target in babies with brachial plexus lesions. If it's anatomically innervated normal, you're totally fine. If the lower trunk has been avulsed, if there's no feed, nothing going into the lower trunk, that is your number one surgical priority in those cases. And you put everything you possibly can into the lower trunk to get the hand to work. And then the secondary considerations are elbow and then finally shoulder. So it is the number one target. It's not important. It's the most important thing in the world for those babies. And that's a really important principle.
That's great. That's great.
Have you had any experience using the contralateral C7 nerve in these instances, or is it somewhere we, as young surgeons or residents, should wait for more data, especially from the Chinese experience?
I don't think we need to know more data, but we happily, for us and probably in Holland as well, those patients are relatively rare. In our practice, we use that if all 5 roots are avulsed and there's no viable way to reconstruct it with direct grafting. In that case, we would use all of the contralateral C7 nerve root large grafts. We pass them behind the pharynx and graft them into all of the lower trunk, because again, getting all of the lower trunk satisfied is your number one target. And then use transfers. You can use intercostals to flex the elbow. You can use accessory nerve for suprascapular nerve. But that's when I would do a cross-neck serve C7. And we've only done that in 2 obstetrical cases, and I think 3 older kids with injuries. And the ones who are long enough out have actually had really good results. So we would not hesitate to do that. But happily, the number of those cases is vanishingly small, at least in our practice.
We have the similar experience. Very rare.
Thank you.
All right. Can you talk a little bit about neuromonitoring, whether you use formal neuromonitoring during surgery, a handheld nerve stimulator, or you haven't found monitoring to be useful for these cases?
I find it very useful. We use like a bipolar direct nerve stimulator. It's just basically like a confirmation what you usually see. If you see severe neuroma formation, and add then the direct stimulation, you see some mass contractions but not real movements. It gives you just a little bit more information to cut the specific element and reset. I find it helpful.
We use even a cheaper 1-lead stimulator because you're just getting a sense of, does this work at all? And in fact, as we've talked about already, I disagree with Dr. Malessy. If we see this severe or significant neuroma, it's going to be cut out anyhow. I don't need a stimulator to tell me to cut out the neuroma.
Okay. All right. And then moving to the technique itself for, let's say, for performing grafting or coaptation. Typically, these are different than vascular anastomoses, usually fewer sutures. I just wanted to see, just having 2 experts to talk about some of the nuances here. For example, I know there's some evidence that using scissors might give a little bit of a crush injury. Do you find that to be the case? Do you use a scalpel or a cutting device to cut out a neuroma?
We use a scalpel, yeah, a new one. We always, yeah, you almost almost for every cut, yeah. And of course, use cottons to protect the phrenic nerve or anything else, and then yeah, we like to cut it with a scalpel. And the sural nerves, we have we call it, yeah, it's a scissor supercut, which is sometimes squeezed a bit, but with these supercut scissors, you also get a nice plane.
How about you, Dr. Clarke? Anything different?
We do the same.
Same fresh scalpel? Yep. Okay, that sounds good. And then for the coaptation itself, do you have a preference? Do you use either 8 or 9/0 suture, 1 or 2 stitches? Depends a little bit, perhaps on the size of the nerve.
Of course, we use 0/0 sutures, if you know what those are. I haven't used a suture to do this in decades. Probably in about 25 or 30 years, haven't used any sutures for this. So that's it. That makes the suturing really easy.
I see. All right. Well, other question I had, but it sounds like maybe you don't use this, but do you, for yours then, do you use a fibrin glue to hold the?
Use fibrin glue for the entire operation. Correct.
I see. Okay.
It has extraordinary advantages. Among others, when you line up some 1 or 2 or 3 sural nerve cables with a cut stump, when you drop the fibrin glue on it, the cables sort of float up into position very nicely, and you can get a beautiful alignment at the two ends, which I've never been able to achieve with sutures. So not only is it easier and faster, you can actually achieve a better result, in my view, than you can with sutures.
I see. Okay.
That's a very nice pearl, and I never really thought about it, but definitely something to consider. Thank you for sharing.
Yeah, no, I've done that a handful of times when, sometimes they just happen to line up so beautifully. I do feel the same way, that if you put a suture, you can only make it less aligned.
Make it work.
Let's see. Yeah. How about in those cases where you have a size mismatch? I know some people will use some type of wrap around the nerve to perhaps prevent stray fascicles from leaving the coaptation site. If you have a size mismatch, will you still use fibrin glue or any other tricks for that?
I'd still use fibrin glue. The other advantage in gluing rather than suturing is if you have a proximal stump and you've looked at it under the microscope, so you know exactly what's going on with that proximal stump. If there's a sweet spot on it that looks better than the rest, and you've only got a smaller nerve cable to put onto it, you can glue it exactly to that sweet spot without introducing any suture into the nerve itself.
Great. All right, that's a good pearl. That's great.
Another question I had, do you rely at all at histology to make sure that you have alive nerve endings, or you just visibly inspect the nerve and say, oh, it's good enough, the neuroma's out, I don't need to do any more inspection here?
We do histology every time on every proximal stump, and still about 10% of the time we are surprised and go back and recut to get a better stump. And even when we don't, we can sometimes say, gee, we're past the neuroma here, but it doesn't look like there's as much myelin in it. It doesn't look as robust. It doesn't look as good. So that other root that's next to it looks better. I'm going to emphasize that and de-emphasize the other. It does influence the final pattern of grafting in our hands.
Yeah. We have the similar experience as regard to the gluing and to the intraoperative histology. I want to add that it is also important if you have a root of Walls, you want to resect the dorsal root ganglion because you don't want to connect the ganglion towards your proximal stump. Because then you have the T cells in the neuron that will not give you any recovery. So we want to be sure that we have resected the complete ganglion as well.
So it's interesting you both use histology. Is that more of a qualitative analysis, or do you have any quantitative thresholds for what you think would be a useful donor?
It's fully qualitative.
Okay. Because I know some people may, 50% staining certain things like myelin, but that makes sense.
We use that, but it is also very important to hear about potential fibrosis or neuroma formation between the fascicles or in the epineurium. That type of information is also important. But we like to hear about especially the proximal stump, whether whether there are myelinated fibers in the proximal stump.
At a conference recently, the audience was polled about the longest gap that they would consider grafting. And, I think not that there was a consensus, but some people said they would graft up to 7 or even 10 centimeters. In those cases, more to prevent neuroma formation. I think this was more in the extremity. But for a baby with a plexus injury, once you've resected neuroma, do you have any limits on how much you would graft? Or maybe forego grafting if it's too large, the gap?
When babies, it's only 4 centimeters from the C5 intervertebral foramen to below the clavicle. So there's your natural limit, because you're rarely grafting to significantly below the clavicle.
Yeah. Usually it is like if you operate somewhere between 3 and 6 months, usually the graft length is like 2.5 centimeters, something like that. 2.5.
Yeah. And if you see a neuroma extending, if you're doing a supraclavicular approach and see a neuroma extending distally, will you basically just put traction on the clavicle rather than cutting it, or do you ever find yourself having to cut through the clavicle?
We never cut clavicle. We pass a loop underneath the clavicle and have a bar above the baby. So it's like a string, and we lift the clavicle, and then you can work underneath the clavicle. It adds 1 to 1.5 centimeters, and usually that's enough to perform your reconstruction.
The other thing, the clavicle is a wonderful splint postoperatively to hold everything out to length and size. So why give that up if you don't have to? If you just dissect the muscles off the inferior border of the clavicle and then a little retraction by whatever means to move it superiorly, you can see all that infraclavicular plexus very well.
Good. Right. And I think it just adds morbidity if that is going through the clavicle. We touched a little bit about sural nerve. Dr. Malessy, I found this from one of your papers. Maybe you could talk a little bit about how you harvest a nerve and the endoscopic option here.
Yeah, these images are very is a good illustration, of course. So first we explore supraclavicular, and then we determine whether we need the grafts, and then we subsequently go to the legs, and via 2 or 3 incisions in the skin line, we use the endoscope to mobilize the nerve, which is a procedure that takes about half an hour to 3/4 of an hour, depending on local anatomy. Morbidity is low. I mean, I think that big incisions, like they were used decades ago, it is really horrible to open up the entire calf. It's not necessary.
Got it. All right, so we've talked a lot about some surgical nuances. If we think a little more now about the postoperative period, will you typically immobilize infants for a certain period of time after a nerve graft or nerve transfer surgery?
So why don't you show the picture?
Here we go. Here's one example.
We use a Velpo bandage done very much like this for 3 weeks afterwards, mostly to prevent the limb from flailing around and to tell the parents, gee, don't grab the baby by this arm. That's our real purpose in using this. And after 3 weeks, we take that off and resume the preoperative physiotherapy.
Right. Yeah, I'd worked with a orthopedic surgeon for a period of time during my fellowship, and he typically would cast children. When I first got to the hospital where I am now, I asked orthopedic surgeon that, and he showed me this swath technique instead. So I think it's a little easier.
Anybody who's worried about this, and assuming you've got the whole arm prepped out during the operation, when you've done the operation, the grafts are all in place and the neck is still open, take the upper extremity, externally rotate it, internally rotate it, flex it, extend it. The grafts don't move more than 1 millimeter or 2. They move very, very little. And if you need reassurance that you don't need a massive cast for these babies, that may help you.
And the casts more often than not slip off, and it becomes more of a drama for the parents coming into the ED in the middle of the night. So yeah, I love this way of putting it in, and I agree with you, keeping it for a short period of time just to not pull the baby by the arm.
Just for the viewers, this basically is kind of a cylinder of stretchy material. If you make 2 cuts at either end, you can use it to tie, and just kind of this makeshift sling or swath.
Not makeshift. It's properly fabricated.
There we go. That's a good term. All right. How about can you talk a little bit about any if you have any rehab protocols or guidelines when working with therapists after surgery?
We always work with the therapist, and we wait until around 6 weeks for the therapies to start to improve the passive range of motion of the shoulder and the elbow. The specific exercises to rotate the glenohumeral joint and check the range of supination and stuff. But this is roughly from 6 weeks onward.
Okay. That's not like Dr. Clarke. Are you more at the 3-week mark for?
Well, we start something very simple at 3 weeks, but start the full-on program at 5 weeks, which is essentially the same answer.
Great. And how about for those cases where, despite intervention grafting, results may not be as optimal as you'd like? Perhaps a baby doesn't return with anti-gravity elbow flexion or shoulder abduction. If you're thinking about secondary reconstruction options, let's say tendon transfer, how long do you give a chance to see if the surgery basically takes and they improve? Is it something that you'd wait 6 months, a year, sometimes even longer in a baby?
It's important to remain very patient in these patients to see the final outcomes. We have very good data showing that the final outcome from nerve reconstruction, particularly in the hand, isn't seen until about 4 years after the operation. So that's a long time. And in fact, sometimes you have to wait a long time even for the elbow to start flexing. So in this, I recommend patience. Most of the secondary options you've got aren't necessarily time limited to a specific point in the baby's life. So there isn't a rush. You don't have to rush in to fix what you think your problem is. You should make sure you know what the problem is first and then go forward from there.
Great. All right. So at this point, I think I've learned a lot from hearing all this. Just want to see, having been in practice for many years, for some of maybe our younger viewers, any big questions that you feel are out there that in this field really should get a lot of focused attention and going forward in terms of research and really kind of big picture in this area?
Well, we are very interested in the reanimation of exorotation. It's something that can be very difficult, and it's not always predictable which children will do well and which won't. So the coming years, we would like to find out whether we can find more clues on how this can be improved. Yeah.
If someone's looking to win a Nobel Prize, my recommendation would be to find a simple, non-invasive way to determine the health and viability of the anterior horn cells in these babies, because we have good experimental data that shows even a proximal scalpel laceration to a nerve root in the neck can cause anterior horn cell degeneration, retrograde death of the anterior horn cells. All of our grafting assumes they're alive and well and living, but if they're not, that may be the cause of some of our less optimum results. If we had a way of knowing whether those cells were working well preoperatively, that would be fantastic.
Well, there are many things that can be improved. I mean, Howard, we haven't. The other item is sensation. So there's most of the research that has been done is focused on movements, muscle activity, whereas there are some studies now done. We have done some that could show that, for instance, the sensation in C5, C6 lesions in the thumb and in the index finger is less, and it doesn't get much attention. How this affects the final outcome of these lesions.
Dr. Malessy and Dr. Clarke, a separate question that comes up often is mode of delivery and brachial plexus injuries. What is the experience in Europe or Canada, and what would be the advice or sage advice that we provide if, I get a call from my obstetrics colleagues in regards on how best to deliver a child, especially if they've had, previous history of brachial plexus injuries?
I have never dared to give delivering obstetricians any advice about how to undertake their craft.
Yeah. No, so this is not my, but what I hear in the Netherlands is that the supine position is one of the is maybe part of the problem. When the shoulder gets stuck, I think that the obstetricians nowadays quicker ask the mother to go to a sitting position, or on their elbows and then on their knees, and that may help to rotate the child and do some obstetric maneuvers to reduce the chance of dystocia.
Thank you.
Right. All right. Well, great. Well, thank you both again. Any last minute comments, or Dr. Rizk, any other thoughts?
No, I wanted to ask the team here, what made you choose this as a specialty? What was the aha moment? Who was your inspiration or your muse that wanted you or inspired you to go into the specialty and help babies with brachial plexus injuries?
Yeah, well, that's a good question. I would think it's a long time ago, but in our department, we had some experience with adult lesions, and in Paris, Alain Gilbert pioneered the work of the neonatal ones, and so we heard it in the European setting. So we just started in the late 80s, early 90s to also see the children. Yeah, and the concepts of reconstruction in that time was more or less the same as in the adults, but quite quickly that deviated.
Yeah. My story, I think, is interesting, at least for me. Many years ago, when all this began, the physiotherapist came to myself and Ron Zucker, two plastic surgeons at Sick Kids who'd never treated these babies, and said we get referrals from the pediatricians, we get referrals from the family doctors to do physiotherapy for these babies, but we know that doesn't make them better. Some of these babies will need an operation. Only very few babies were being operated at that point by the neurosurgeons who would come to Sick Kids and do the adult operation for the babies. So the therapist said, gee, could you start seeing these babies? And Dr. Zucker and I had both done lots of peripheral nerve surgery, so it seemed like a natural thing to add to our repertoire. And we started doing it with a textbook open on the stand in the operating room to find our way around. It's not the right way to learn, but that's how we started.
Obviously, it takes a lot of practice and lots of knowledge, and babies are way different than adults, especially in tissue dissection. Their scarring is potentially, very. So any chance you have watching it in another OR or going to the cadaver lab is definitely something to utilize before you get into this type of surgical intervention.
In the 21st century, you should be fully trained to do this before you start doing it yourself. There's so many opportunities to train now that no one should have to invent this again.
And I would like to add that the treatment of these children is a multidisciplinary treatment.
Mm-hmm.
So you need to build up a team. You can't
Mm-hmm.
do this on your own.
Mm-hmm.
Yeah. The surgery, the nerve surgery, is just a part at the beginning of a long trajectory.
Mm-hmm.
So you need a team with specialized physiotherapists and orthopedics and plastic surgeons to get the ultimate result.
Mm-hmm.
Yeah, definitely a team sport. And I think, like you said, the training's available now in part because of a lot of the the groundbreaking work that you both did and contributed to the field. So thanks very much. And yeah, I appreciate you taking the time to talk with us today.
Thank you.
You're very welcome.
Pleasure.
Thank you, Dr. Clarke. Thank you, Dr. Malessy.
Thank you.